True. So welcome everyone to ACMT Grand Rounds. It is October 13th, 2020. We are joined here graciously by Dr. Andrew Francis. This was an excellent referral by Dr. Racimus. He's going to talk to us today a little bit about catatonia. He's professor of psychiatry, associate director of residency education, and director of neuromodulation services at Penn State School of Medicine. He's a co-developer of the Busch-Francis catatonia scale, and he's a authority on neuroleptic malignant syndrome, malignant catatonia, ECT, and delirium. And I'll turn it over to you, Dr. Francis.
Thank you very much, Nick, for the introduction and the opportunity to present. So I've been working for many years on catatonia, and so this talk will reintroduce you to catatonia. I show some video of what it looks like, and I'll slant most of the talk to latter half of the talk to drug-induced catatonia, and in particular neuroleptic malignant syndrome, NMS, framing it as a drug-induced form of malignant catatonia. So I have no disclosures. I'll be talking about off-label use of treatments for catatonia and neuroleptic malignant syndrome. There's no FDA-approved treatments for either of these. I do have a website that's sponsored by Penn State University where I work. Very easy to remember, catatonia.org. And it has a lot of information about catatonia and some videos as well. This is a textbook picture from an old German textbook of a patient with catatonic stupor showing posturing catalepsy. So catatonia was first described back in the 1870s by a German psychiatrist. And he was working at a psychiatric hospital that he owned in Eastern Germany. And he described some unusual patients in his monograph that was translated into English in 1973. Beautiful case descriptions. Patient remains motionless, rigid, eyes staring, devoid of will to move or react. It can be full-blown, and I'm going to show you gross examples, or it can be a graded phenomenon, less severe or intermittent. The impression conveyed by the patient is one of profound mental anguish or immobility. Tends to be persistent. And Kalbaum himself, writing in 1874, makes note that catatonia is associated with medical illnesses, and in particular, what he's calling here muscular disorders. We would now call them neurological disorders. And the examples in his era were epilepsy and neurosyphilis. So the first person who described it really said most of the important things about it, which is that it's a variable syndrome, tends to be persistent, can wax and wane, and it's associated with medical illness and neurological illness. So what does it look like? So I have in my collection of videos many examples of real patient videos that I've collected over the years before, during, and after treatment. But for the purposes of this presentation, which might be recorded, I'm going to use publicly available videos. And these are historical videos. And these and others from the historical era of the 1930s and 40s, old black and white silent movies, they're on my website as well, which is catatonia.org. So this is a patient from the early 1930s. The patient's on the right, the doctor's on the left. So it's a low quality, old black and white movie with no sound, but it shows a phenomenon that we can still see today. And you'll see what the patient looks like and how he reacts to the examiner. So his arm remains in an upright posture where it was previously placed, and you can see that the examiner moves the limbs and they stay in unusual postures, which may persist for long periods of time. And notice how the whole body seems to be rigid. There's no fluidity at all to the man's posture. He may remain in this unusual rigid posture for extended periods of time. He's not talking to, the examiner. He also shows mutism, another catatonic sign. And he's blankly staring, not really engaging with the examiner, who is moving him around. We'll see a close-up of his face here. And you'll notice that he's blankly staring, he's mute, he doesn't engage with the examiner. So it's staring, mutism, withdrawal, rigidity, and catalepsy. Multiple catatonic signs that are all. So this man represents the classic form of what's called withdrawn or stuporous catatonia, where the person is often not talking, maybe not moving, might have a rigid posture, doesn't seem to engage with the environment. If you're wondering, if you've never seen somebody who has neuroleptic malignant syndrome, they look quite a bit just like this. They're often very stiff and rigid, so-called lead pipe rigidity. Have this sort of dazed look. They will often have multiple autonomic signs: fever, diaphoresis, tachycardia, labile, pressure, and pulse. Have skin that is quite wet from excess perspiration and also excess sebaceous gland activity. So they will have this greasy, wet appearance to their skin, which he has to some degree. It's very hard to capture on this old video. Are there comments or questions from this video? And Nick, how are we handling comments or questions during the talk?
So we'll just have you raise your hand, and I'll hit the unmute button if you have any questions or comments.
Okay, so you'll moderate that?
Yep.
Okay. All right, so I'm going to show you, so this is a very classic form of catatonia, and most of the patients I'm talking about have this stuporous or withdrawn form of catatonia. He's a very severe case. Patients like this can persist for days, weeks, or months. There are complications, which I'll talk about later, of this if it's persistent and severe and untreated. But most of the patients are less severe than this. He's a very severe example that you couldn't miss it. If you saw a patient like this, it would be quite obvious that there's something drastically abnormal. Now, there is also a hyperactive form of catatonia. So there's subtypes within catatonia, for example, hyperactive and hypoactive, or excited and retarded, you might say. Other subtypes might be a benign catatonia or a malignant catatonia. Malignant catatonia would be that form of catatonia associated with severe autonomic symptoms, like fever, tachycardia, diaphoresis, autonomic instability. The hyperactive form, two common characteristics are overactive movements, movements that are constant or overly frequent or bizarre. So this man is another example from probably the 1940s. He's showing repetitious odd movements. And these movements look odd the first time you see them. So these would be called mannerisms on our rating scale. Stereotypies are also frequent movements, but the abnormality is in the frequency of movement, not the nature or context of the movement. So for example, someone who is rocking back and forth, it's not unusual to rock. It's just that they keep doing it in a persistent fashion chronically. Mannerisms seem to involve parts of the body used for communication, like the upper body, the hands, and the face. And it's as if they were ritual or signals. And you'll see he does things in a sequence, sort of odd movements, touches himself a certain number of times in a certain number of places. So you can see he's ritualistically touching himself in a sequence. The left hand does a certain thing, the right hand does something different. He's also passing a piece of paper back and forth, and he's in constant motion. So he's overall hyperactive, but in particular, he has these repetitious, ritualized movements. And it's as if they were a ritual, so to speak. So this would be mannerisms. Much more subtle is that he's got some grimacing in the face, which is another catatonic sign. Okay. So these are examples of two classic examples of catatonia. One is the more common stuporous, retarded, or withdrawn catatonia, and the other would be a hyperactive or excitable catatonia. So I just showed these as exemplars of what it can look like. So is this a historical relic, or do we still see this? So this is from a review paper that we published. We were trying to influence the DSM-5 committee. The DSM-5 committee is the committee that writes the Psychiatric Bible, the Diagnostic and Statistical Manual version 5. And they weren't too enthusiastic about the idea of having diagnosis codes for catatonia. And we were trying to persuade them that it's real and it does exist and it's severe commonly. So the first part of the slide is we reviewed prospective studies looking at the incidence of catatonia in adult inpatient psychiatric units. So our study was Bush et al. Third study listed here, and we screened prospectively 215 consecutive inpatient psychiatric admissions and found about 7% had catatonia. Most of the studies since then have used our rating scale, which I'll talk about shortly. And if you look at these studies in slightly different methodologies of how they assessed and how they diagnosed catatonia. But if you look at these studies over 20 years, about 9% roughly of patients admitted to a psychiatric unit are going to have catatonia to some degree or other. And it's important to note that most of them will have mutism, which means they don't speak or speak very little. And they will have a high rate of negativism and withdrawal. So withdrawal is the patient doesn't engage with the environment. Negativism is they actively resist attempts to make them engage with the environment. So it's present, and when it happens, they generally don't communicate or interact well with the environment. What about the prevalence in general medical surgical populations? So in a general hospital, medical surgical floors, we don't actually know that. There haven't been, to my knowledge, prospective studies of looking at consecutive admissions and screening them systematically for catatonia. If you look at psychiatric consultation services in terms of their retrospective chart review records of their consults, it's 2 or 3% of the consults they see. But this is quite an underestimate, most likely. And there's been a couple of prospective studies in the ICU with delirium patients, and there's a high rate of coexisting catatonia and delirium in the ICU setting. So catatonia has a differential diagnosis, and there are a variety of things. Disorders that can have a catatonic presentation. So a variety of metabolic disorders or inflammatory disorders, lupus, ketoacidosis, uremia, porphyria, thyroid disease, all of these are case reports, case series sometimes, associating them with catatonic presentation. And it would typically be of the retarded or stuporous form of catatonia. Neurologic disorders, both localizing and non-localizing. So reviews of medical catatonia typically show neurological disorders as number 1 or 2 as the quote inciting cause, so to speak, of catatonia, where it's secondary to some definable illness. And encephalitis, infarction, meningioma, seizures, all of these are associated with catatonia. Especially for this audience, toxic inductions of catatonia. Well, there's a classic phenomenon known as steroid stupor, where a variety of psychiatric disturbances can happen with corticosteroids, manic, depressed, psychotic, delirious, but also catatonic. It's called steroid stupor. PCP, a hallucinogenic drug, is associated with catatonia. There was a well-described case series from the early 80s when there was an epidemic of PCP in Baltimore. Disulfiram, a drug used to treat alcohol. There's quite a case literature on disulfiram-induced catatonia. A variety of miscellaneous agents. Neuroleptic-induced catatonia, primarily the older high-potency, strongly dopamine D2 blocker drugs, things like haloperidol, for example. This was first described in the 1970s, drug-induced catatonia. And then I'll show evidence for why we think that neuroleptic malignant syndrome might be considered as a drug-induced form of malignant catatonia. Catatonia is also associated with psychiatric illness, primarily mood disorders, things like mania and depression, psychotic illnesses, sometimes conversion disorder. You can have conversion paralysis, conversion blindness, you can have a conversion catatonia. And there's an unusual syndrome called manic delirium, which is a severe form of a bipolar manic phase where the patient is extremely hyperactive and they cycle between being confused, manic, and catatonic, often with autonomic disturbance. Those patients are uncommon. They tend to get worse with antipsychotic drugs and respond well to ECT. There doesn't seem to be a particular pattern of catatonic signs or a lab test, such as an EEG or a blood test, that will identify medical or secondary, so to speak, catatonia versus psychiatric catatonia. Now, this is, of course, subject to more research, but as of today, that really remains true. So there's no particular pattern of signs and symptoms of the catatonia that allows you to say, well, this is more likely associated with some sort of metabolic or neurological condition or drug reaction versus idiopathic catatonia or that associated with a psychiatric illness. So I published a chapter in drug-induced catatonia in this book, edited book on catatonia that we published about 15 years ago. And there's more detail about various drug-induced catatonia in that book. So as you might imagine, the severe form of catatonia, especially the retarded or stuporous form, there are medical complications of that. And most of them are the medical complications that you might see in anybody who is not moving and bedbound. So things like pulmonary embolism, rhabdomyolysis, breakdown of muscle or skin, decubitus, seizures, renal failure, aspiration pneumonia, swallowing reflexes are often disturbed in catatonia. There's risk of aspiration. So people who have severe persistent catatonia, efforts should be made to protect them from these complications. The one that probably is most likely rapidly to occur would be blood clots, embolic phenomena. Patients who are not moving, who are dehydrated because they're not eating, these are risk factors for blood clots. So might consider some form of mild anticoagulant and certainly aggressive treatment of the catatonia when it's severe and persistent. So over the years, we've addressed several questions in catatonia. First, the prevalence and phenomenology, how to assess it and measure it, what its treatment response is, subtypes, excited, retarded, acute and chronic, primary and secondary, and benign and malignant. So I'll focus on discrimination from other motor syndromes. Can you tell catatonia from Parkinson's or dyskinesias? The short answer is yes. This aspect about looking at neuroleptic malignant syndrome as a drug-induced form of malignant catatonia, which I'll talk about in the second half of the talk. And other aspect that's intrigued me more recently is the delirium with catatonic features. So we could answer questions in any of these, but I'll tell you mostly about prevalence, phenomenology, and treatment, and NMS. So we developed, is there a question?
Yeah, it would now be a good time to ask a couple quick questions.
Sure. Yes, absolutely.
So from Dr. Osterhout, we have, what is catalepsy and how is it different from catatonia?
Catalepsy is a symptom of catatonia. So in our rating scale, we published a rating scale 25 years ago, actually. And we developed it because we had a resident interested in studying catatonia. And I told him, his name was George Bush, by the way. And I told Dr. Bush, as a second-year resident in psychiatry, well, if you want to study something, you need a way to measure it. And the result was the Bush-Francis Catatonia Rating Scale, which we published, and it's used worldwide now. It's been translated into several languages. It's used in clinical care and also in research. And I am answering this question about catalepsy. So on this rating scale, there are 23 signs. And one of them is posturing and catalepsy. So catatonia is a clinical syndrome. That is to say, what is a syndrome? A syndrome is a collection of signs and symptoms that adhere together. That is to say, if it has an onset and an offset, those things come together, they occur together, and if it's treatable or reversible, they go away together. That's sort of the conceptual model of what a clinical syndrome is, a collection of signs and symptoms that travel together, get worse together, and get better together, if it's a reversible syndrome. So how many signs and symptoms do you need to define a syndrome? Well, in our early research, we wanted to capture the milder cases, so we set a very low bar. We set a bar of only 2 items out of this first 14 on our 23-item scale. And we were going to define the case by at least 2 of those first 14 items. And then all 23 items on this rating scale could be scored on a 3-point scale as to how severe or prominent they were. And we operationally defined all these things as to what they are and how to measure them. So caseness would be number of signs and symptoms, at least 2. And then severity would be rating all 23 items on a 3-point scale. So we could use the same rating scale to make a diagnosis and also rate severity. One of those signs of catatonia is catalepsy. So posturing and catalepsy, we call them the same thing. What they are is the person has an unusual, they're holding parts of the body against gravity in unusual or even mundane positions, but for too long. So as on that video that I showed, the doctor moved the patient's arms and the arms stayed where he left them. If the patient does the same thing himself, it's posturing. If it's done by the doctor, it's catalepsy. But the thing is, the phenomenon is the same, which is the body part stays where it is and has been placed, either by the patient or by the examiner for extended periods of time against gravity, often in an uncomfortable position. That's what catalepsy is.
Great. There's one other question. Is in your list of diagnoses on the differential?
Yeah.
Are you familiar with NMDA receptor antagonist
Yes.
encephalitis being included in that differential?
Yes, that would be a form of encephalitis, so to speak. So a variety of encephalitis, infectious encephalitis, inflammatory encephalitis, have been associated with catatonia. There's a whole literature on NMDA receptor antibody encephalitis. And there's been actually good studies now, prospective studies, that show high rates, 60, 70% of those patients at least have catatonia, and perhaps the others aren't adequately assessed. So there's an extremely high rate of catatonia in NMDA receptor encephalitis. There are case examples of psychiatric treatments being given, such as ECT, electroconvulsive therapy, to people who turned out later when the tests came back and the studies were done to have NMDA receptor encephalitis, but they actually got better with psychiatric treatments like ECT. So there's a case literature on that. So it's another form of a secondary catatonia, that is to say catatonia associated with a definable brain abnormality. Other comments or questions?
Oh, we'll let you go on and ask you again later.
Okay. The DSM-5 defines the Diagnostic and Statistical Manual in Psychiatry, 5th version, which is the current version. Their concept of catatonia is 3 signs out of 12. In our research, it was 2 out of 14. So the 2 out of 14 is a low bar, and that was designed for psychiatric patients who have been screened not to have gross medical or neurological illness. If you're looking at medical patients or ICU patients, the recent research that I was collaborator on shows that we need a higher bar. The best sensitivity and specificity is using 4 signs. But for psychiatric patients who are generally ambulatory, 2 signs would suffice. And catatonia diagnosed by the Bush-Francis method or by the DSM method highly correlate, about 95+% overlap. This catatonia rating scale is freely available on the web. I should get a nickel for every time it's used, but I don't. So we prospectively applied this, as I mentioned, in our hospital to identify a prospective cohort, and we wanted to learn about the phenomenology and the treatment response. And with respect to the treatment response, there were some case reports that lorazepam, which is a benzodiazepine commonly used in psychiatry, was able to treat drug-induced catatonia. And it hadn't really been systematically studied in a quantitative way using a methodology that could rate the severity and operationally define catatonia. So we decided to investigate the potential of intravenous lorazepam as a treatment for catatonia. And the way we did this in our prospectively identified psychiatric patients with catatonia was to try intravenous lorazepam. So we were giving, in retrospect, relatively small doses. We would give them 1 milligram of lorazepam, the brand is Ativan, and rate them after 5 minutes, and at baseline after 5 minutes, and then give them a 2nd milligram and rate them now at 10 minutes from baseline. So this is a 10-minute treatment trial in this intravenous study that we did. And if they were cured or had catatonia resolved, that was the end of the treatment. If not, we continued the treatment for up to 5 days. And these are the results from the intravenous lorazepam dosing. So what's on the y-axis is the score on the catatonia, Bush-Francis Catatonia Rating Scale. It's 23 items, 3 points each. The maximum will be 69. Most hospital patients with catatonia are going to score between 15 and 25 on that rating scale. That would be prominent catatonia. And that's what these patients had. And then after 1 milligram of lorazepam and 5 minutes, they were rated again. And 10 minutes, 2nd milligram of lorazepam. So that's 2 milligrams total over 10 minutes total. They were rated. And what you see is a greater than 50% drop in the catatonia severity scale just within 10 minutes and 2 milligrams of lorazepam intravenous. Some patients, catatonia completely resolved, some patients it didn't change, and some patients had a partial response. But overall, the average response was very dramatic. This became the basis of what's now known as the lorazepam challenge test, which is, in a sense, a diagnostic confirmation and also an initial treatment for catatonia. So this is commonly used in psychiatric settings or in medical surgical floors where catatonia is suspected as a treatment challenge to help confirm the diagnosis and look for a treatment response. We continued the treatment for up to 5 days, and the lorazepam was in doses of 4 to 8 milligrams, up to 8 milligrams a day by any route, oral, IV, or IM. And of the 21 patients that we were able to treat with lorazepam, what we discovered was that 2/3, 3/4 of them show a good response to lorazepam within a few days, but some don't. So this has been repeated now many times. And about 2/3, 3/4 of patients with catatonia, as defined by the DSM or the Bush-Francis method, will respond to lorazepam. Some won't. They typically will respond to alternative agents, perhaps ECT as well. And what we find is that if there's an initial response within the first day or so, that's a good sign that there will be an ultimate good response. So more generally, what about treatments for catatonia? There doesn't seem to be a placebo. There does not seem to be a placebo response. There's only one placebo-controlled trial, and it used an older drug, which is a barbiturate, amylbarbital. The brand is sodium amytal. And this study was done in the 1980s. It also was a 10-minute study of intravenous response using a homemade rating scale for alertness. And it found a very similar phenomenon to what we found. But in that study, there was placebo arm of saline infusions, which did nothing. Lorazepam has never been used in a double-blind controlled trial. Convulsive therapy from the 1930s, ECT, before that, drug-induced convulsions. First patients were catatonic, and that's why ECT survived, because they responded so well. There's some risk of making catatonia worse or inducing it with neuroleptics, especially the older high-potency antipsychotic drugs, first-generation antipsychotics, as they're called. There's a case literature and case series literature on a whole variety of agents, anticonvulsant agents, L-DOPA, lithium, anticholinergics, sporadic reports here and there, nothing really systematic. The most well-established treatments for catatonia are benzodiazepines, in particular the lorazepam, which seems to be superior to other agents for unknown reasons. There must be something peculiar about the pharmacology of lorazepam compared to, say, diazepam. Other GABA-A, although no double-blind controlled trials, just open trials, but many examples of them, and also everyday clinical experience. It's a well-established clinical observation that 2/3 to 3/4 of the patients who are catatonic will respond to lorazepam. Other GABA-A agonists, such as zolpidem, have been used. There's some prospective trials, open trials with zolpidem on medical catatonia and also psychiatric catatonia. There's some evidence for NMDA active agents, amantadine and memantine. They have other properties as well. And memantine may play some role in the treatment of cognitive impairment with catatonia, such as the examples of delirium with catatonia, but this is subject of some inquiry at present. And there may be some role for atypical antipsychotics, which is controversial. We can talk more about that. So now, kind of with an introduction to what catatonia is and how it's treated, I want to talk about this idea of neuroleptic malignant syndrome as a drug-induced form of malignant catatonia. And again, malignant catatonia means catatonia associated with severe prominent autonomic symptoms, things like fever, diaphoresis, excess perspiration, tachycardia, hypertension, labile pulse and pressure as well. All of these things are reported. And there is a neuroleptic malignant syndrome information service, and I'm on their scientific board. There's a website that's got information, some guidelines for treatment and assessment. We later developed a rating scale for neuroleptic malignant syndrome, and that's posted on this website as well. So what is neuroleptic malignant syndrome? It's conceived of as a drug-induced disorder with extrapyramidal and autonomic signs, especially fever. What are those extrapyramidal signs? So they're worse forms of drug-induced extrapyramidal reactions. So things like rigidity, tremor, stiffness, slowed movements, rigid posture, classic extrapyramidal symptoms, but of a severe type. It's often of this so-called lead pipe rigidity, like a pipe you could barely move in the limbs, and altered mental status, confusion or catatonia in particular. It's rare, it's potentially life-threatening. It's associated with antipsychotic medications and other medicines with dopamine blocking properties, such as those drugs used in GI disorders like, I can't remember the generic name for compazine, prochlorperazine, Phenergan, droperidol. So there's a variety of GI drugs that are relatively outmoded nowadays, but are associated with dopamine blockade and have been reported to produce NMS. Potential for morbidity and mortality, but it's quite rare. And so there aren't good systematic prospective data on this. So research criteria were published by Stan Karoff and Steve Mann. Exposure to the drug, of course, is necessary. 7 days by oral or depot medicine, long-acting injectables, 2 to 4 weeks. Specified degree of fever, 38 degrees. I believe that's 100.6 Fahrenheit. Muscle rigidity, not specified how severe. And secondary signs like altered mental status, tachypnea, diaphoresis, sialorrhea, etc., and exclusion of other disorders. So NMS is a diagnosis of exclusion. And there's a vast differential, which we'll talk a little bit about shortly. The DSM-5 Diagnostic Bible of Catatonia has slightly different criteria. In our research, we use DSM-4 and Karoff-Mann. So it's very similar: exposure to the dopamine antagonist drug, specified degree of fever, generalized rigidity, CPK, which is enzyme from muscle that's elevated in neuroleptic malignant syndrome, often massively so, hundreds of times normal. Mental status change, autonomic symptoms, and tachypnea or tachycardia. So the incidence of NMS is really unknown. There aren't really good prospective studies, but the larger studies show a lower incidence. Certain risk factors, of course, the principal risk factor is exposure to deep dopamine blocking drugs, the dehydration, agitation, pre-existing catatonia, pre-existing brain damage, drug withdrawal, and rapid dose escalation and parenteral agents seem to be risk factors. So if you're looking at someone who has a mental status change, delirious catatonic, has fever, and has neurological symptoms, there's a vast differential. Of course, infection, CNS infection. Brain tumors may be associated with motor abnormalities and also fever. Brain trauma, brain injury, such as you can have with post-hypoxic sympathetic syndrome. This is an unusual reaction to hypoxic brain injury, where the people have cycles of being extremely rigid with sympathetic autonomic symptoms. Seizures, seizure associated with fever and may be associated with muscle rigidity. Malignant catatonia, which can occur on its own spontaneously. Malignant hyperthermia, that's a rare reaction to anesthetic agents. The setting there is very telling. This is a person who just had anesthesia. They're very rigid and they have a fever. but they don't necessarily have exposure to dopamine blocking drugs unless they receive them during the surgery. Serotonin syndrome is milder usually than NMS. It's associated with GI hypermotility and different agents inside it. Anticholinergic delirium, they might have fever, they might be confused, they might be catatonic, but they won't be rigid. Severe Parkinson and with L-DOPA withdrawal, it's pharmacologically similar to having dopamine blockade. It's dopamine withdrawal, so there's a lack of dopamine, and that can produce a reaction that looks like neuroleptic malignant syndrome. Heat stroke, they will be confused. They will have a fever, but it will be hot outside, and they won't be rigid. Dystonic reactions, acute extrapyramidal reactions to agents like haloperidol or other high-potency dopamine blocking drugs, they'll be stiff. Motor rigidity, they might have some mental status change, but they won't have a fever. Drug withdrawal, they may have a fever and confused, but they won't be rigid. So there's differential diagnosis, vast differential diagnosis. Complicating this is that psychiatric patients can have a high CPK and it may occur in isolation. So elevated CPK in the serum is associated with, it's found after being agitated, it's found just from being psychotic, it's found after giving IM medications, and with physical trauma that, say, produces muscle bruises. So Herb Meltzer did a study in the 1990s. It was a point sample of patients in the psychiatric hospital. They basically just went through the psychiatric hospital and took blood samples and everybody there. And what they found was quite surprising, which was, unbeknownst to anyone, lurking in the background were patients with very high CPKs. 10% of them had increased CPK in the serum. And the median value was 9,600. Normals, usually in most labs, 200 or less. So it's a massive increase in CPK, no symptoms, no renal effects. Not usually associated with extrapyramidal symptoms. It may come and go. And there's some evidence from later studies that this elevated CPK that some patients have who are on antipsychotic drugs, or even if they're not, is a risk factor for more potential for NMS. So if you have a patient who just happened to have this sort of benign CPK-emia, and they develop a fever from a cold, now they have a fever and a high CPK, and you're concerned that they might have NMS, but in fact, what they might have is a cold and this benign pre-existing CPK elevation. Also complicating the diagnosis is drug fever, so to speak, with clozapine. So this has also been studied in a few studies, reported in a few studies. So it's a variable rate, depends how you define the fever. So various cutoffs by the height of degree of the fever. It also seems to be benign. It may come and go, and it may benefit from acetaminophen, usually not associated with symptoms. Again, this is something that may be just lurking there in the psychiatric population that's not really assessed, unless they happen to get a temperature check. And sometimes stopping the drug, the fever goes away, and then re-challenge, it may no longer be present. So all of these complicate the diagnosis of NMS, because here's an alternative reason for fever, and the previous one was alternative reason for high CPK. So work before we began to get interested in this had shown that behavioral signs are often the first early symptom of NMS. When you look at, try to track back from patients who develop NMS, what occurred in the background in the days and weeks prior. And some studies of this type specifically showed a catatonic prodrome to overt NMS. So our approach to this, since we had a systematic way to look at catatonia, was to explore this interface and question of what's the relationship between NMS and catatonia. And we took 4 lines of approach. The first one was, we had this prospective sample, prospectively identified cohort of psychiatric patients. Did they have NMS? In fact, some did. And did they have things that looked like NMS? Now, we know lorazepam is a treatment of catatonia. What about specifically autonomic symptoms for the patients that had those? Did that get better with lorazepam? So we looked in catatonic patients for things like NMS. And then secondarily, we reversed it. We identified patients with NMS and looked for catatonia and looked to see, does their NMS improve with lorazepam? So that was the logic of addressing this question. So in our prospective cohort, again, these are psychiatric patients that we prospectively identified. 3 of them actually met criteria for neuroleptic malignant syndrome. Why? Because they had fever and they were rigid, which are the 2 cardinal symptoms of NMS. They also had high blood pressure and tachycardia. So 3 of them, these were catatonic patients who actually met criteria for neuroleptic syndrome. They met the DSM criteria. And in that cohort of 28 patients, there were other patients who had autonomic signs. Some of them had low-grade fevers, but weren't rigid. Some of them had hypertension. Some of them had tachycardia or bradycardia. So there were autonomic signs within catatonia, and some of them actually had outright criteria for neuroleptic malignant syndrome. We looked more closely at the interface of the autonomic signs and the CPK blood level. So in this sample of prospective cohort people with catatonia that we identified, we had been measuring CPKs on most of them, but not all of them. And what we found was the 3 that had NMS, they typically show very high CPKs. That's classic for NMS. The 2 patients who had a fever but weren't rigid, they had a high CPK. The patients who had other autonomic signs but not fever, hypertension, tachycardia, diaphoresis, they also had elevated CPKs, and our lab normal was 195. And then the patients who didn't have any autonomic signs had normal CPKs. So this kind of got us to this concept of a spectrum, that there's a, quote, benign, unquote, form of catatonia. There's catatonia with autonomic signs. There's catatonia with more autonomic signs. And then there's malignant catatonia, in this case, neuroleptic malignant syndrome. So this kind of was the evidence that would link neuroleptic syndrome and catatonia, and also offer some concept of a spectrum of severity between the 2. So now we're going to go the other way, and we're going to try to look at NMS patients defined only by the criteria of NMS, none of which specify catatonia, and see if they in fact are catatonic. Because NMS is rare, we didn't actually create much of them, so we had to do this in a chart review method. And the way we did that was looking for high CPKs above 1,000 that wasn't otherwise explainable, and eventually located 16 patients who, these were medical surgical patients, not psychiatric, medical surgical patients in the general hospital, and they were there to treat their fever and other symptoms. And 16 of them met rigid diagnostic criteria for neuroleptic syndrome, and they met all the criteria within the same 24-hour period. And what were those criteria? As Karoff and Mann were the strictest criteria, high fever and at least 5 of these other things. And the DSM are a slightly milder criteria. It doesn't specify the degree of fever and only 2 of these secondary signs. So this is a milder criterion, and this is the more severe criterion. The DSM is actually more similar to the Karoff ones now. It's an improvement over the DSM-4. And these were the symptoms that they had. They had high fevers, which range from 100.5 to 104. They had high serum CPKs, which ranged from 162 to 7,200. Mean was 2,200. Had leukocytosis. They had tachycardia, which could be very high. So they had the typical autonomic disturbances that you see in neuroleptic malignant syndrome, and they also had muscle rigidity. They met criteria all within the same 24-hour period. Now, in a retrospective fashion, most of them were seen by neurology or psychiatry, and so there was descriptions of their behavior. And we were able to show that this group of 16 people who were identified as having neuroleptic malignant syndrome, in fact, were catatonic. So 15 out of 16 met the Bush-Francis, 15 out of 16 met the DSM-4 criteria, and they had an average of 5.5 catatonic signs. They would meet DSM-5 as well if we studied them nowadays. So these were patients identified as having neuroleptic malignant syndrome. There's no catatonia in that definition. And when they're examined within that same 24-hour period, there's descriptions, even from retrospective study, that allow you to say they also met criteria for catatonia. And so the question now is, well, are the catatonia and neuroleptic malignant syndrome symptoms related? Do they co-vary? So at the time, there was only one very simple-minded rating scale for neuroleptic malignant syndrome. It had been published and used in a single case report. So it looked at motor, autonomic, mental, and lab, one of each, one item from each of these domains of NMS. How severe was the rigidity? How many autonomic disturbances did they have? Did they have agitation, confusion, delirium? And how high was their CPK? None of these are catatonia. Okay? So there was anywhere from 0 to 8 possible points for, quote, severity of the NMS. And now we had a way to measure catatonia by using our retrospective Bush-Francis catatonia rating scale. So now we can address when the NMS is more severe, is the catatonia more severe? And the answer is yes. So on the x-axis here is the severity of the NMS using that 8-point score. And on the y-axis is the severity of catatonia measured here by number of signs out of the 22 items. We excluded autonomic here. And there's a positive correlation. That is to say, the more severe the NMS, the more catatonic signs they had. And there's no overlap between what's measured on the NMS scale and what's measured on the catatonia signs, catatonia scale. Okay. So we took this as strong evidence, really, that NMS and catatonia are related. They co-vary. They occur together. And why not be parsimonious and say that one is a version of the other? What about treatment? So we were hoping that this identified population of catatonia, NMS patients, some would get lorazepam, some wouldn't. Turns out they all got lorazepam in the range of 3 milligrams a day. And their symptoms all got better within 2 to 3 days max. So the rigidity, the fever, the CPK, the white count, the blood pressure, pulse, confusion, diaphoresis, incontinence, all these things got better within 2 to 3 days. So in this study, days to recover from the NMS with lorazepam were about 1.5 days on average. One of our ex-residents published a 2-patient case series with treating NMS with lorazepam. They got better in about 2 days. And later, we published a second study. These were 3 patients who had NMS from atypical or newer antipsychotic drugs. These patients were all the older antipsychotic drugs. So this is the literature up until recently on use of lorazepam to treat NMS. How does this compare to other treatments? Well, supportive care alone, which would be intravenous hydration, cooling blankets, things like this, takes longer. So to conclude, and I'm going to leave a few minutes for questioning, catatonia is a distinct syndrome associated with morbidity, severe and untreated. Medical, psychiatric, and toxic associations had subtypes, including malignant catatonia. All these forms of catatonia often respond to treatment if diagnosed, things like lorazepam, potentially ECT. There is, I think, reasonable evidence to support the concept that neuroleptic malignant syndrome can be viewed as a drug-induced form of malignant catatonia, which of course have treatment implications for treatments with things like lorazepam and ECT. Benign neuroleptic fever and benign CPK-emia are clinical challenges because they can be occurring in the psychiatric patients who are exposed to these drugs. Consider lorazepam in addition to supportive treatments for both catatonia and neuroleptic syndrome. And not subject of this, but we did eventually publish a much more comprehensive neuroleptic malignant scale, NMS rating scale. So thank you very much for allowing me to present. I hope it's been useful and reasonably coherent, but I'd like to hear any kind of questions.
I've been cataloging questions.
Yes.
A lot of great questions, and that was an absolutely fantastic presentation. Thank you. The first one is, it seems that there's a lot of overlap with Tourette's and catatonia such that you might tick off a lot of the criteria in the diagnostic criteria
Yes.
that you put in a patient with Tourette's. Can you just comment on that?
Well, I agree with the observation. So it's what else they travel with. So again, catatonia is a syndrome. It's not one thing. So we look for a collection of signs and symptoms. And so take a closer look at those Tourette's patients with the catatonia rating scale. And there may be some existing literature that I'm not aware of using things like lorazepam to treat Tourette's, or a more comprehensive assessment of to what degree do they have other catatonic signs and symptoms.
Great. In regards to, you spoke a little bit about the lorazepam challenge for
Yes.
catatonia. Is that similar conceptually to the phenobarb interview for conversion disorder?
Well, the phenobarb interval for conversion disorder, I think, is a sodium amylbarbital interview for conversions, the so-called Amitol interview. I don't think it's phenobarbital, but maybe it could be used in the same way. It's similar in the sense that it's a intravenous drug with a GABA A agonist property that may relieve catatonia. I'm not sure what the question is aiming at, though.
Let's see. Sage, let's see. I can unmute you if you want to further elaborate. Let's see. Chat.
Ask another question in the meantime.
All right. In the meantime, how did you decide to try lorazepam? Was that something that you'd
there was some case literature that a couple of case reports that lorazepam was used to treat neuroleptic-induced catatonia, but it had never been systematically studied in a quantitative way. These things I'm showing you were the first ever quantitative assessments for catatonia and outcome measured in a quantitative systematic fashion.
Great. Sage, I've made it so you can unmute yourself if you want to elaborate.
Sure. What I was trying to get at is in terms of it revealing something about the underlying pathophysiology, or is it something that's primarily a psychiatric issue and the sedative properties addressing that or is it something that's addressing the underlying pathophysiology of it?
So let me answer this way. Can we infer something about the biology of catatonia from what is known about the mechanisms of action of its treatments? Is that?
Yeah, I think that's a better way of phrasing what I said.
Okay. So this is neurologizing. So if you look at these various diverse manifestations of catatonia, so the most common one would be the catatonic stupor, withdrawn, not moving, rigid, stuck. There is a hyperactive form as well. So how do you link the two? So what I would say is catatonia represents a dysmodulation in the normal activity pattern that is in context with the environment. So you're sitting here watching a talk, you're not jumping up and down and bouncing off the ceiling, okay? Because what's called for is to sit and watch the talk. If you're playing basketball and you're sitting there not doing anything, it's out of context. You should be jumping up and down. So there's a normal modulation of the behavioral activity pattern with the environment. Catatonia is a breakdown of that. When it's called for movement, they're not moving. When it's called for fluid movements, they're stuck and rigid. When it's called to sit still, they're showing stereotypies and mannerisms, odd movements, constant movements, strange movements, bizarre movements. When it calls for interaction with the environment, they're withdrawn and mute. So there's a dysmodulation between the behavioral pattern or motor activity levels, so to speak, and the environment. That calls to mind other movement disorders, things like Parkinson's, where movement is called for, but movement is slowed or stiff. Or Tourette's, where no movements are needed, but vocal and motor tics occur. Or other motor disorders, bulismus, dyskinesias. So those all live, so to speak, in the basal ganglia. So what's in the basal ganglia? Well, you find dopamine and GABA. So in this kind of simple-minded neurologizing, well, dopamine blocking drugs make catatonia worse or can cause it. They block dopamine, it's big in the basal ganglia. GABAergic agents, GABA A agonists like lorazepam and zolpidem relieve catatonia. So this neurologizing concept would say maybe it has something to do with basal ganglia functions or circuits, like the cortical striatal loops that affect GABA and dopamine. But I don't go too much for this neurologizing stuff. that's the sort of logic that, so in that book that I mentioned, there's a chapter there on theoretical mechanisms of catatonia, but it basically involves these circuits in the basal ganglia. But I don't really buy into it too much. Other comments or questions?
That's great. If you're thinking of this as a spectrum disorder, how do we approach treatment? Does lorazepam need to be used as described for catatonia with daily max doses and schedule dosing, or can it be titrated to effect?
For neuroleptic syndrome or for catatonia?
Well, it seemed like you were implying that there may be a spectrum disorder of on which they kind of join. So
yes. Right. So the malignant catatonia sometimes responds to benzodiazepines. Tends to get worse with antipsychotic drugs, and that's certainly true for NMS. And ECT is sort of the ultimate salvage for all of these things.
Yeah, I guess the reason the question came up is because typically with NMS, we do kind of symptom-triggered management with our GABAergic drugs as opposed to scheduled dosing. And it seems like in most of the catatonia literature, it's suggested that there be a scheduled benzo dosing with a daily max dose. So I guess, how do you see, do you see a role for symptom?
Well, yes, I certainly would do scheduled doses for both, for all forms of catatonia, including neuroleptic malignant syndrome. Its initial doses are low, 1 to 2 milligrams, and titrated as to higher dose ranges. So sometimes catatonia doesn't respond to medium doses of lorazepam, and there are case reports of people needing 20, 25 milligrams a day to respond to catatonia.
What do you, and that kind of parlays into the next question. What
obviously do you? Obviously not on the first day. It's titrated up over some days.
See. And what do you recommend then for this? You presented some data where 25% don't respond. Do you recommend higher dosing or switch to another drug?
Well, it depends on what else is wrong with the patient and how available ECT is. So ECT essentially salvages all patients with catatonia. The studies are pretty clear on that, although there aren't double-blind controlled studies of ECT and catatonia. But there's plenty of open trials and clinical experience. And if ECT doesn't resolve the catatonia, you might question about the details of how the ECT was done. So if ECT is available and feasible, and the catatonia is severe and persistent, that's a good option. But in those settings where it's not available for one reason or another, or not an option for one reason or another, then high-dose lorazepam is an option. And second-line agents, things like memantine, perhaps L-DOPA, perhaps amantadine.
Do you see a role at all for bromocriptine?
For catatonia, there's a couple of case reports on that. And so agents like bromocriptine and dantrolene have been recommended for neuroleptic malignant syndrome. There's actually 1 or 2 papers that say it was worse than just supportive care. And they have some, each of them has toxicities.
In the circumstance where, I guess, in your opinion, if you have a patient with NMS, neuroleptic, obviously, can you restart that NMS? How long after? What's the best approach?
Oh, the longer you can wait, the better. The studies that have looked at this, they're all retrospective, try to wait at least 3 weeks and shift to a, quote, less strongly dopaminergic blocking drug. The longer you can wait, the better.
I have one more question.
Yeah.
It's a long one. So some patients presenting with immobility, mutism, staring, and autonomic signs clear relatively quickly, and sometimes we attribute those with antimuscarinic toxicity or high potency THC. Is it appropriate to refer to these shorter duration presentations as catatonia, or should that terminology be reserved for prolonged intoxications or accompanied medical or psychiatric conditions?
Oh, catatonia may be brief. So it's a clinical, well, let's take delirium. So delirium is a clinical syndrome. It has a certain collection of signs and symptoms. You can be delirious for an hour or months. The same is true for catatonia. Although brief catatonias aren't that well described or studied. But my position would be that it's a diverse clinical syndrome, and those times in which they have the signs and symptoms, operationally, they have the syndrome, and it can be short-lived. It can be long-lived. I'm not sure I'm
No, I
giving
think,
too simple-minded an answer to,
no, I
to a
think
more sophisticated question.
no, I think that's a good answer. Sometimes I see patients like that. I guess it's fair then for me to say they exhibit some signs of catatonia regardless of the etiology.
Yeah. Now, some workers would say that to be, quote, real, unquote, catatonia should persist for at least 24 hours. I mean, I'm sympathetic to that, but it's not part of the definition.
Great. Well, that was an excellent presentation. It is 1 p.m., so we'll end the meeting here. Thank you very much, Dr. Francis, for taking the time.
Okay, and that recording, if anybody recorded this, is those patients are in public domain, so it's okay to distribute the video.
Wonderful, wonderful. Thank you very much.
Okay, my pleasure.
Take care.
Bye-bye.